sinuses, then it goes into the heart, and that way it's going into the heart muscle itself while the heart muscle is relaxed. That makes any sense?
Yeah.
Okay. So here's what they look like. Here they are coming off the trunk of the very first part of the aorta here, just above the aortic valves, in the aortic sinuses right here. Here's the right coronary artery going down this side, the left coronary artery going down this side. Now you'll need to know the coronary anatomy, and I'll show you some videos of some arteriograms that are done to show where the blockages are in these vessels. But oftentimes you've heard of people getting 2 vessels revascularized, or a 3-vessel bypass, or even up to 5 vessels rehooked up. The way that's generally done is you take a piece of saphenous vein out of somebody's leg, you turn it around backwards because it has valves in it, and you hook it into the aorta right here, and then you just leave it hanging out here in the breeze. And if the blockage is right here, for example, you want to plug in down below the blockage. Okay? And if the blockage is right here, you might want to bring another one down to this blood vessel. If there's another blockage right here, you might bring one out to there. This little vessel right here is called the left main coronary artery. You just call it the left coronary artery, but it's the left main. The left main is going to divide into 2 branches, the anterior interventricular artery and the circumflex artery. Honestly, we always call this one the LAD, the left anterior descending. Okay. So the anterior interventricular is fine. It's coming down through that interventricular septum that we talked about. But the main coronary artery here is called the widowmaker. And the reason for that is most people who have a narrowing in the widowmaker between here and where it splits right there, they have a left main coronary artery occlusion, they usually die from it. When they have a little heart attack, they're gone. Why? Because the left coronary artery, this one artery, supplies almost all of the left ventricle, which is basically your pump, which is where, you know, the wall is thick and you need all the strength. So the left main is called the widowmaker. You'll see, I think that's in your book, but that's what we always called it. People that were found out to have a left main narrowing in the cath lab were immediately taken to the operating room. Do not stop at go, do not stop at the elevator. You take them straight into the operating room and fix them. Because just by having a catheter put in there and dye squirted in there, that could be enough to have them occlude their left main. And if they occluded their left main, they were gone. Okay? This is the back side of the heart. This is where the blood goes out through those arteries I just showed you. This is that circumflex coming around, like we just mentioned. Here is the right coronary artery over here. It comes down, goes down the back side. But most of your ventricle, most of your left ventricle, your important ventricle, gets its blood from the left coronary artery. When the blood comes out of the heart muscle itself, it flows back through these coronary veins. They collect here on the back of the heart as the coronary sinus, and the coronary sinus then dumps straight into the right atrium, and it goes out through the lungs again and goes around. The right coronary artery supplies the right atrium, portions of both ventricles, marginal arteries. Just know that most of the right coronary artery is not nearly as important as the left coronary artery, because remember, the left coronary artery goes to the left ventricle mainly, and the left ventricle is really where this all happens. So almost every patient that has a heart attack in the left system over here, because this is the one that it just needs so much more oxygen, so much more blood. And when blockages occur on this side, that's a much bigger deal than blockages on this side. Left coronary artery, the main one we talked about, the widowmaker, supplies blood to the left ventricle, the left atrium, and to the interventricular septum, that thing that goes down the middle between the 2 ventricles, that band of muscle, because that also carries your electrical system down through the interventricular septum. There they are. I think I've already talked about this. Have you guys ever heard this term anastomoses? Let me go back to this picture here. This is an example of an anastomosis between different blood supplies. So let's take this little piece of heart muscle right out here. You notice that it has blood coming from this side and it has blood coming from this side. In other words, these blood vessels are anastomosing. They're coming together in this area. So that if one of them got blocked off, the other one would probably be there to save the day and keep blood flowing to that area of the heart. That's what an anastomosis is. And that's why patients can get so far along with this disease and have so many different narrowings before they have any problems. You know, guy might have a little chest pain one day. He's never had any problems before. He thinks he's in pretty good health. He walks into the doctor, and the doctor says, well, that sounds like angina. Oh, your EKG shows looks like you had a little tiny heart attack. Better check that out. And you go in there and you find out he has blockages in 5 different places. And he needs a 5-vessel revascularization. Well, he got to that point only because he had all of these anastomoses, so the blood can get in from different directions. Okay? Right way. Here's an example of a arteriogram. Dye is the red stuff here. You see that it's injected here into the root of the aorta, basically. It comes out here through, this is one of the coronaries, this is the other one. And you notice those arteries all look nice and big and open and so forth. On the other hand, over here, you squirted the same dye in and you've got virtually 100% narrowing. It's not 100, it's about 99% because some is getting through to this thing. But you notice all along here how irregular it is. That's an example of a bad heart. This guy needs several, he needs better blood flow. Either balloon it open, put in a stent, or do a surgery on it. All right. Let's talk about the heartbeat, single contraction of the heart. This is something I'm going to go over with you, but believe me, you're going to need to go over this in your book and go through this step by step. You need to understand the phases of a single heartbeat called the cardiac cycle. And that's not a bicycle, that's a cycle. So the way we want the heart to work is we want the atria to contract first, the ventricles to contract second. Okay? When the atria connect, that sends more blood down in the ventricles, so the ventricles have more blood to work against, and then when they contract, they can send it either to the lungs or to the body. We have 2 different kinds of cardiac muscle cells. Most all of them are muscle cells. They produce contractions and they cause the blood to flow. But we also have a bunch of cardiac muscle cells that have sort of specialized. They've become specialized to conduct this electrical charge to allow it to spread out around the heart so the whole heart can contract together. If you talk about this, the cardiac cycle begins with an action potential. This is the pacemaker of our normal heart, is in what's called the SA node. So you need to understand the SA node. The SA node lives up in the atrium, and it fires off about 75 times a minute. And that charge is then scattered around the rest of the atrium, and then eventually it works its way down into the ventricles. We can look at that with great accuracy because of this test here called an ECG. Now, it really should be ECG, but everybody calls it EKG, okay? Just no difference. We just always refer to them as EKGs. And you've probably heard it like that too. These are the electrical events that occur in the cardiac cycle that you can actually look at on a piece of paper. Now, how does a EKG work? Well, you put little leads on arms and legs, and then you analyze 2 of them at a time. And the reason you do that is because you're kind of looking at the heart from this direction, from that direction, this direction, that direction. There's actually a total of 12 leads that we can do on your heart. So, real quickly, and then I'm going to stop for today because we're out of time. The thing starts here at the SA node with a little pacemaker happening. That little pacemaker is called the P wave right here, and its first little wave is the firing off of that SA node. You see that on an EKG. This is a standard EKG lead. So this is called the P wave, this is called the QRS wave, this big thing here, and this is called the QRS. This is the T wave. So this thing fires, it sends the shock across the atrium down here to this thing called the AV node. The AV node then sends it on down through the bundle branches and through the scatter out around the rest of the heart. Then the whole heart gets its shock and it fires all together to make it happen. So we'll go through this thing step by step. I would recommend, if you can, read ahead on this before the next lecture, which won't be until next Wednesday after the test on Monday. Okay?